A very good evening to everyone. A warm welcome on this eighth session of the Upper Crest. It's a unique initiative which has been guided by Dr. Ajay Kakar and an initiative by Inkemi, one of the fastest growing pharmaceutical company today in India. We are a proud partner. We are a proud group company of Alchem in India, sir. It's my privilege today that I'm welcoming Dr. Ajay Kakar, the founding member of Upper Crest, which is a unique initiative to upgrade the dental fraternity and the latest and the best in dentistry. Today, Dr. Kakar will talk to us on dental hypersensitivity. So, a very good evening and welcome to you, sir.
Thank you.
I also extend a very warm welcome to all the dentists who have joined us from India and abroad. We get a good number of dentists who have supported us from Nepal. So, a warm welcome to everyone. Uh, it's our eighth session, and we have a lot more that comes to our platform every Sunday on 7:30. So thank you so much for your interest. Uh, Definitely, we have heard all the stalwarts like Dr. Kakar, Dr. Bahuguna, and Dr. Shravan Kumar in our past deliberations. Today, to talk on hypersensitivity, I will now hand over the session to Dr. Ajay Kakar, who will take us through. And over to you, sir.
Thank you very much. I will just start my screen. So I hope my screen is visible.
Yeah, it's visible, sir.
Excellent. So my topic for today is innovations in therapy for tooth hypersensitivity, and I will talk about various things involved with it. But I was very happy to note that you have got there are a lot of questions which have coming through, and Nishant is already packed with questions. If I'm not mistaken, he had a couple of questions on pertaining to the last week's topic. And if he wants to, he can ask me and I can answer those two questions before I start off in tooth hypersensitivity. If he wants to.
Sir, I think we can carry on with the session, then
Okay.
we'll come back to that.
Okay, fine. We'll carry on with the session. So innovations in therapy for tooth hypersensitivity. So as I've always told before also, that when I lecture, I do not have a problem if you ask me a question in between while I'm lecturing. I'm perfectly fine with it. In fact, I'm happier if you ask me questions in between because it makes me a little more involved in it, because then I know that there are people who are asking me questions, there's things which are coming up in people's mind and they're asking me things. So I'm very happy if questions are put forward to me in between my presentation also. I'll keep on doing it. I'll wait for it for you to ask me questions in between, which makes me feel happy. Happy about things that they are going the way we want them to go. Okay, so therapy for tooth hypersensitivity. Now you'll wonder that tooth hypersensitivity, is it such a big thing? Is it so big? Is it so important for us? In a certain way, maybe not, but in a certain way, maybe yes. In fact, I would err on the side that I would call it maybe yes. It may be a problem, and I call it a nuisance value problem. Nuisance value problem, what I mean is that it is a problem which is there and we tend to avoid it because we don't know how to sort it out. And because we don't know how to sort it out, we try to find some or the other means or ways to solve the problem. So I'm going to take you through a lot of things in hypersensitivity. I myself have worked on a different methodology for treating hypersensitivity much before I came about a new way today, which is there for the last 10 to 12 years with me. But before that, when I was doing my MDS way back in 84, 85, I found a beautiful way to treat hypersensitivity. I will talk to you about that also. That's also possible. That is also possible. But today I don't resort to it because I don't need to do it, because I've got something else which is equally good and works very well for me. So let's look at a little bit of hypersensitivity now. Now, when do you get the hypersensitivity? Whenever there is an attempt to scale, restore, etc., it can be a very unpleasant, it could be a very unpleasant experience. And this experience is not enjoyable. It causes issues. About 1 in 4 patients complain to me whenever I scale for them. They keep on doing ooh, and they keep on stopping me all the time. Now, I personally work in a totally different environment. When I do scaling, I do it at one shot. Now, I mentioned scaling because attempt to scale is one of the most problematic things when hypersensitivity hits you. Now, how do I do scaling? I do not have what we call as a spittoon in my clinic. I have mentioned it to you in the earlier lecture that I do not have a spittoon in the clinic. Because I don't have a spittoon, all the ejections that is happening is through a high vac saliva ejector. A high vac saliva ejector automatically takes away everything that collects in the mouth, which includes the plaque and the calculus, which also collects over there. Now, when I do scaling in that way, it definitely temporary. There's some amount of sensitivity that happens, but this is a transient sensitivity. This is taken away, this is eliminated over a period of 6 to 7 days. Just a short time and you can eliminate it. Just give me a moment and I will be back in a second. My door is closed and I don't want the internet to malfunction. So just give me a moment, just a moment. Sorry, I'm back. It was not a major thing. I'm back here. So let's talk about when does hypersensitivity occur? What is hypersensitivity? It is a state of transient tooth pain. In this, the most important thing is what? It is a state of transient tooth pain. When I say transient means temporary. It's a temporary tooth pain that happens, which can be caused by a variety of exogenous stimuli. The exogenous stimuli can be cold, tactile, or osmotic changes because of sweet or drying on the surface. These are the stimuli which cause the problem, and we don't want this stimuli to happen because it can lead to a major problem. It can lead to a major problem that a person may actually stop the intake of such food which causes this stimuli. For example, people love ice cream. A lot of people love ice cream. And I know a lot of people who have not taken ice cream for the simple reason, oh my God, I would love to have the ice cream, but the moment I have the ice cream, I get severe sensitivity. And because of that, I've stopped taking ice cream. This is such a common thing which is told to me. Would you people agree with me on this? Nishan, just say if somebody is agreeing with me on this. I just want you to say yes or no, that's all. Or just type a yes and Nishant would get the answers and I would be able to, I will know that people are listening to me and understanding what I'm saying.
Yes, sir, on it.
On it, okay. Now, these are the kind of stimuli which is there. And this is the common problem which is reported by patients to me. So how do I treat this problem? Let me go ahead with this. We did a small study. I actually carried out this small study of this transient short, sharp pain. 52% people do not seek dental advice. This is quite an alarmingly big number. And 75% patients do not use or have not used a special paste for it. This is also a big number. But the bigger number is 52% patients do not seek dental advice. This is not good. You should seek dental advice because only if you seek dental advice, you go to the next step forward and get your problem sorted totally. If you don't ask the dentist, how will you know what is the way to sort the problem? Modality of hypersensitivity. Now, how does hypersensitivity happen? It's very simple. I'm sorry, there's a small spelling mistake there. It should be Brainstorm's hydrodynamic. I missed a D over there. Very silly of me to miss a D over there. I was typing fast. I must have missed the D. It is Brainstorm's hydrodynamic theory. What does the hydrodynamic theory say? It says on stimulation, exposed dentinal tubules allow for fluid flow within the tubules. So within the tubule, what happens? Fluid flows out and thereby causes pain. The fluid flowing out causes the pain, and we don't want that pain to happen. Because we don't want the pain to happen, we do not expose it to a stimuli like that. So this is the way, and this is the most widely accepted theory of hypersensitivity. This is just a little bit of theory. I'm just letting you know, talking to you about it. What you see over here, what you're seeing over here are small tubules. These are exposed tubules on the dentine surface. This is a tubule. This is a tubule. This is a tubule. And here you see an exposed nerve fibril. A little bit of the nerve is also exposed. So this is something that we do not want to happen. And we hope that it will not happen. Now, what causes hypersensitivity? What leads to this hypersensitivity? The first and foremost cause of hypersensitivity is abrasion. Now, what is abrasion? Would somebody want to respond? What is abrasion? We have got abrasion and erosion, and we also have something called abfraction. We are going to talk about all of them, but abrasion happens because of toothbrush wear. The toothbrush rubbing against the tooth creates a V-shaped notch, a slight notch, and this notch is where the dentine layer which is covering, the enamel which is covering, gets reduced and reduced and reduced till some point, until it reaches a certain point when the dentine is actually exposed. When the dentine is exposed, it causes hypersensitivity. Now, it can happen due to dietary reasons, overzealous brushing. There are certain people who will brush and brush and brush and brush and brush and brush. Most people do not brush and brush and brush and brush, but there are certain people who brush and brush and brush and brush. So overzealous brushing or faulty brushing, incorrect way of brushing. The second is erosion. Erosion is in addition to abrasion. It can happen. And the third is called abfraction. Now, what is abfraction? Abfraction is a structured removal of some part of the dentine, some part of the cementum and the enamel. Sorry, not dentine. Some part of the cementum and the enamel, which causes abfraction. This is usually happening due to lateral occlusal forces which the tooth is subjected to. And then, of course, you have the all-pervading gingival recession. When do you get gingival recession? Whenever you have got periodontal problems. Anytime you have got a slight perio problem, the gingiva reacts by running away from the source of the problem. If continued for a long period of time, the gingiva recedes. The moment the gingiva recedes, you start having sensitivity. This is called periodontal disease. And of course, improper oral hygiene methods. This is, I've already spoken about it in point number 2 up over here, what we call as overzealous brushing or faulty brushing. And then we have iatrogenic. What do you mean by iatrogenic? Self-created by the dentist. So not self-created, but created by the dentist due to some dental procedure in which certain attention was not paid and a little bit of dentine was left exposed. You leave dentine exposed, and what is it causing? It is automatically causing, you have the dentine exposed means dental hypersensitivity is bound to come. It comes after post-scaling, but post-scaling is generally controlled very well. But it can also happen after faulty bonding. I have not really spoken about bonding dentistry because I had other people talking about bonding dentistry. But there are a lot of people who face this problem. A lot of dentists face this problem. And when you're doing bonding dentistry, when you try to ensure that there is no air which is entrapped in the composite. This does not happen 100% of the time, but sometimes it does happen that some air gets trapped in. And when the air is trapped in on exposed dentine, that becomes a source point of continuous dental hypersensitivity. This is called iatrogenic. And lastly, it is because of faulty tooth reduction. You may think that this tooth is coming in the way, so you go out reducing it. And then you reduce it so much that you reach the dentine. You remove the enamel which is protecting it. Enamel is a protective layer on top. Enamel prevents sensitivity. To give somebody all the pain in the world, all you have to do is grind the tooth at some place to remove the enamel, and now the patient is a definite candidate for sensitivity. These are abstraction reasons. You can see this, how these lesions present themselves. This is gingival recession that happens. Now, how do we treat hypersensitivity? I'm cutting it short. I'm not getting into details of hypersensitivity, into details of why the hypersensitivity is happening. I've already covered that in the previous slide. This slide covered it totally in my presentation. All the possible causes of hypersensitivity are laid out over here. So this is how do you treat hypersensitivity? This is the way you treat hypersensitivity. First step is to let nature take its course. Allow nature to work. Allow the patient to get used to it, or in other way, some reactions happen in the mouth because of the saliva, and somehow the sensitivity reduces. That's great. Let nature takes its course. But nature always does not take its course the way we want it to do. The way we want it to do is automatically all sensitivity should stop, but that doesn't happen. There are people who suffer from constant sensitivity. And the people who suffer from constant sensitivity, nature has not taken its course, then you have to intervene. You have to intervene in some way to let the reaction happen in such a way that now no longer the patient will be sensitive. So what can you do? What you can do is desensitize the nerve, making it less responsive to stimulus. Or you can plug the dentinal tubules to prevent the fluid flow, which automatically stops sensitivity from happening. Now, just to tell you what happens in sensitivity is when the fluid comes out, sodium is pulled out, potassium is pulled out, and sodium goes into the tubule. And this is what causes the sensitivity. Sodium-potassium reaction that happens at the dentine interface, which is exposed. The sodium-potassium interchange happens in a reverse way, the way it should not happen, and you get the problem of desensitizing, of sensitivity. So you can do these two things. You can change the way the nerve reacts. Sorry. You can change the way the nerve reacts, making it less responsive to the stimulus. Or the other way around is plug the dentinal tubules to prevent the fluid flow. Now we got a third way also. I'm going to talk about the third way later on. Slightly different. I call it regenerative method of treating hypersensitivity. It's a slightly different way. We are going to look at it. So natural course of action is dentine sclerosis that happens. Sclerotic dentine forms on the dentine surface, thereby blocking the open dentinal tubules. Or calcium oxalate plugging of the dentinal tubules happens. Or the nerve itself, because of the sodium and potassium available, and potassium nitrate, which is in some small form available in the saliva, works to depolarize the nerve. So either of these three things can happen. But because Nature cannot always do the trick for us. We cannot leave it as a natural course of action for it to happen and all the problems to get sorted. So what we have to do is actually try to solve the problem. So let's look at what do we do to actually try to solve the problem. Home care options. What are the home care options that we can do? You can use a soft bristle brush. Ideally, all brushes should be soft. You should not be using a hard brush at all at any point of time. Or you use a powered brush. A powered brush also does very well. A powered brush also helps in such a way that it goes slightly in between teeth also, where you have got some amount of periodontal disease. It goes between the teeth and prevents sensitivity from happening. Modify the grasp, use the circular technique. These are the methods of using a right methods of using a brush. Once you use the right methods of a brush, everything works brilliantly, works wonderful. Next is to select a proper dentifrice. I will talk to you about it slightly later on. And one can always do one thing, dietary modifications. Like what? Stop eating sweet. But can you always want to do that? You don't always want to do that. You want to try enjoy the sweet things. You want to enjoy everything. But moment you eat the sweet, you get a severe sensitivity. So we don't want that to happen. So dietary modification is not one of the best ways to sort this problem. You can use home fluorides, toothpaste with some amount of fluoride, which helps you with just 200 ppm of fluoride, which helps you control the sensitivity. But all this again, all this is similar to the natural course of action, in which what happens is the sensitivity does not get 100% sorted. Because the sensitivity does not get 100% sorted, we have a problem. So we have a problem and we want to sort it out. You can also do certain things with toothpicks, burnishing with the toothpick. You see what we are doing? We're having a toothpick and you push the toothpick in between the tooth surfaces, the proximal wall of a tooth surface. Can everybody see this? Please respond to me. Can you see this? What I'm trying to show you? Can you see my...
Yes, sir. It's visible, sir.
Yeah, but I want to know from people, are they able to see it? I would love some people to respond. Come on, somebody respond to me, please. I feel much better, much more happier when some people are responding to me.
Yes, sir. There are some responses. They can see that.
Wonderful. So
Yes.
they are saying yes, right? Lovely.
Yeah.
Burnishing with a toothpick is a simple self-care approach which can reduce sensitivity over time. So you can burnish it with a toothpaste, with a proper toothpaste which you have been prescribed. It could work very well. Or a Proxia brush or an interdental aid. With any of these things, what you can do is prevent some amount of sensitivity from happening. So this is a nice way to prevent sensitivity from happening. Now dentifrices. We have a lot of dentifrices. Potassium nitrate, potassium oxalate, strontium chloride, stannous fluoride, sodium citrate, formalin, ferrous oxide, and Sensodyne repair and protect. Now, what are these dentifrices doing? These dentifrices are an aid. They help you in preventing sensitivity. How do they help you in preventing sensitivity? I will just talk to you about it. But out of all these which are there, out of all these variety of dentifrices which are there, which are a very good aid to help you prevent and help you stop sensitivity. These are some of the excellent ones as potassium nitrate, and Sensodyne repair and protect. I am highlighting two special items in this. One is called potassium nitrate and the other is Sensodyne repair and protect. It doesn't matter from which company you take the dentifrice. If you're taking potassium nitrate, you can take potassium nitrate, let's say Thermosil RA, rapid action. Thermosil rapid action is a very, very good potassium nitrate based paste, and it works very efficiently. Let us just try to see how does it work. As I said, nerve desensitization is done, or occlusion of dentinal tubules is done. The first one, what did I say, is nerve desensitization. What is also known as nerve depolarization. What do we call it? We call it nerve depolarization. Nerve depolarization means this nerve, which was otherwise sensitive to a small stimulus, now will no longer be more sensitive at all. But this happens as long as somebody is using Thermosil RA, rapid action, or Sensodyne potassium nitrate, any paste like that, which is constantly used by the patient in the mouth, it will prevent sensitivity for, let's say, 24 hours. But it needs to be replenished again because all the potassium nitrate, I'll just tell you how it works. Let's see how it works. This is the way it works. Potassium ions travel along the dentinal tubule and prevent repolarization of the nerve. Normally, what happens when there is sensitivity that is happening, the nerve has got potassium inside it. This potassium tends to leach out because of the stimulus. The stimulus pushes the potassium outside. Because the potassium is being pulled out, what is replacing it? Sodium is replacing it in the mouth. So we got sodium coming in, potassium going out, and this is the main problem that causes sensitivity. Now, if you make the tooth in such a way that tooth is no longer sensitive to this, it's called depolarization of the nerve. So the nerve is no longer depolarized, then it works very well. It works excellently then. So this is how you use a potassium nitrate based toothpaste. What happens is the potassium nitrate forms a layer, thin layer outside. The thin layer prevents the potassium from coming out and sodium from going in. So prevents the sensitivity from happening. There is no sensitivity that is happening because of the depolarization of the nerve that has taken place. We have got a lot of literature evidence which exhibits a high level of success with this form of depolarization. The next thing is to occlude the tubules. Can you see what is happening? Sorry. Can you see what is happening? These are tubules. These tubules are open. These open tubules are what causes the sensitivity. If there is an open tubule, a stimuli which is applied to this tubule causes the potassium to come out and sodium to go in, and it causes sensitivity. You can depolarize the nerve, but that works only for 24 hours. It's not a permanent cure. If you want a permanent cure, you have to, in some way, block the tubule. These tubules which are there, they have to be somehow blocked. If you block the tubules, then what happens is these tubules are not open anymore to form sensitivity. They do not create sensitivity at all because they are blocking the nerve over there. Okay. So I will just explain to you how can this be done. This can be done with varnishes, can be done with restorative materials, can be done with glass ionomer, can be done with bonding agents, can be done with pastes, etc., etc., etc. So you have a lot of agents which can be applied on the tooth surface. But what is the problem with this? Everything has a solution, but every solution also has an inherent problem. Let's go back. Let's just go back. What is happening over here? the sodium potassium depolarization has been done. So this nerve is no longer sensitive, but it's only for 24 hours. Within the next 24 hours, you have to again use the potassium nitrate, and the potassium nitrate has to be applied, and then again it has to form a barrier over there, depolarize the nerve. So again, the potassium doesn't come out, the sodium doesn't go in, and the nerve is fine. But you have to keep on doing it every day. So this is a small problem. The second one is, where we got a problem is, we can block the tubules. We can block the tubules very well. How do you block the tubules? You block the tubules by using some kind of material. Some kind of material means it can be done with varnishes, restorative materials. I already told you all this. Now, what is the issue with these materials? These teeth are subject to occlusal forces. These teeth are subject to what? Occlusal forces. When they are subjected to occlusal forces constantly, over a period of time, that means over a period of 2 months, 3 months, 4 months, these tubules which have blocked the dentine tubules like this have been blocked, these tend to open up. Once they open up, the sensitivity reappears. So you got the first one, depolarization works only for 24 hours. You got to replenish it constantly to prevent repolarization to happen. So you got an issue. If you block the tubules, it's fine, but it doesn't remain blocked all the time because of toothbrush usage, because of any other usage. Ultimately, the tubules open up and these tubules create a problem. Now we have something new which has come up. This is called Novamin. Let me explain to you what is Novamin. Novamin is, I'll just give you a historical perspective first. Novamin was first made as a bone regenerative material in oral and orthopedic care. It was discovered way back in 1969, but nobody could find any practical utility for it in dentistry. So it was just a product which was on the shelf with the metallurgists. They had the lovely product. They did not know what to do with it. So nothing was done with it. In 1985, Dr. Larry Hench, I will show you who's Larry Hench. Oh no, I don't have Larry Hench's picture over here. Dr. Larry Hench was the person. Dr. Larry Hench was the person who figured out that he can use this material for regenerating new bone. It was used as a bone regenerative material. It was used as a bone regenerative material in oral and orthopedic care. Now, in 2000 came the big discovery. When Novabone was a product, it was also called as Perioglass originally. The Perioglass Novabone product was used. To make the product, they had to make it of a certain particle size. Now, when they are making it of a certain particle size, the part which was very narrow, very, very small in diameter, less than 90 microns in diameter, was thrown away, was not used at all. And I'll just tell you a small story that Novamin came to be christened as a product because this was a product that was thrown away usually. When the particles, bioactive glass was made, Perioglass or Novabone was made, they would throw away the particles less than 90 microns in size. And these less than 90 microns in size was then of no use. Till one person came up with an idea. He thought, why should we not use it as a paste? So he worked on it as a paste and he found some fantastic results with it. He found some fantastic results with it. And these results were amazing and very good. What did he find out? He found out that over a period of 7 days, just 7 days, Novamin creates a new hydroxyapatite-like layer over the exposed dentine. And this new hydroxyapatite layer was actually bonding to the existing dentine. That means now this layer had a beauty. I call it regenerative treatment of hypersensitivity. Regenerative treatment of hypersensitivity. Because what was happening is it was creating a new layer of hydroxyapatite, which was like hydroxyapatite, looked like hydroxyapatite, behaved like hydroxyapatite, but it was not exactly like hydroxyapatite because it did not have the dentinal tubules, which was still better. It was a hydroxyapatite layer which was there above the material, and this material was excellent. So this hydroxyapatite-like layer was used as a desensitization product. It was called, and the name given to it was Novamin. Let us see a little bit more about Novamin. Essentially, a micro-sized powder that is lesser than the size that is used for bone regeneration. Chemically, it is the same as the regenerative calcium sodium phosphosilicate. This is the actual constituents of it. 45% silica oxide, 24.5% calcium oxide, 24.5% sodium oxide, and 6% potassium oxide. These are the materials that made up the Novamin. And this Novamin, when used in the form of a paste, worked excellently well for the patient. Let's see some results out of it. Before we see the results, let's see what is the reaction that happens. Novamin reacts with saliva, allowing sodium ions to exchange with hydrogen ions, raising the pH. Moment the pH is raised, sensitivity reduces. Sensitivity reduces because of the reaction of the Novamin particles with saliva. At this elevated pH, calcium and phosphate precipitate as calcium phosphate. Calcium phosphate crystallizes to build a new hydroxyapatite-like layer over the exposed dentine and within the dentinal tubules. And this becomes what we want to be present over there as what we call as regenerative method of treating hypersensitivity. The calcium, sodium, phosphate, silicate. These are SEM pictures. These are SEM pictures. These are the SEM pictures of this calcium, sodium phosphosilicate. These SEM pictures bind to the existing dentine. It forms a strong bond with the dentine and just is there to do whatever you want. And this creates a biomimetic hydroxyapatite-like layer over and within the exposed dentinal tubules. So here we have these tubules which are bound by this layer on top. This new layer is not subject to removal from toothbrush by toothbrushing. Toothbrushing does not impact it because it is actually bonding to the existing dentine over there. The existing dentine is bonding to the tooth. So lovely. It is exact bonding to it. It is not subject to pressures by biting and eating because it's become part of the tooth itself. So this is not something which is blocking the tubules, which is being taken out. No, that is not happening. What is happening over here is that it becomes part of the tooth itself. So it creates what we call as a biomimetic hydroxyapatite-like layer over and within the exposed dentinal tubules. Now, structure of this layer. The structure of this layer is that it is very much similar to natural dentine. This is similar to natural dentine. But what is the benefit? Simple. It is 50% harder than dentine. Why is it harder than dentine? Because there are no hollow tubes inside it. There are no hollow tubes inside it. So there are no hollow tubes. So what happens is it is a structure which is stronger and harder than dentine, and it works beautifully. It works very, very beautifully. It works like great. Ever since I came across Novamin, and well, let me just share a small experience with you. Okay, first I'll finish talking about Novamin, then I'll talk to you about my experience with Novamin. It is firmly bound to the collagen in the dentin. It absolutely binds to it. It's a strong layer which is binding over there and it's working like a dream. Let's see this. Day 1, day 2, day 3. Day 1, before using Novamin, what do we say? Day 1, we see Novamin, you just did a brushing with Novamin and you see Novamin particles all over the place. See, this is high magnification. We have got Novamin particles all over the place. In day 2, just in a matter of 48 hours, a lot of Novamin particles are already inside the tubules. And they have started the formation of calcium phosphosilicate. That means hydroxyapatite. These are the crystals which form the hydroxyapatite. So here we have in day 3, most of the dentinal tubules are blocked with this. They are not just blocked, they are blocked with this naturally growing hydroxyapatite-like layer on top of the exposed dentin. And this does not go anywhere. To remove this layer, you'll have to actually cut it out with a diamond Fisher burr. You cannot remove it. Even scaling does not remove this layer because this layer becomes part of the tooth surface. It is very much part of the tooth surface. It is very much there and it's there, constantly there. There we see pre-brushing, post-brushing and post-acidic challenge. These are some SEM photographs. Now I am privileged enough to have access to these SEM photographs. Now I'll tell you my story of Novamin. I have been a strong proponent of NovaBone or Perioglass as it was known from 1985 till year 2000 and after that also. From 1985 till year 2000, I've been strongly using NovaBone or what was called as Perioglass. When the scientists at NovaBone, that company was also called NovaBone by the way. It was originally called Orthovita, then the company was taken over by Art Votis, and then it was called as NovaBone. And one of the scientists, Randy Scott, was the president of the company. And what he's found is that there is this material which was being thrown away, which I told you about some time back, Novamin, which was being thrown away. And then the scientists said, let's do a study with this. They did a study outside the mouth. They did a study outside the mouth, in vitro study. They studied outside the mouth and they were quite happy to see the end result. Now, these people were in constant touch with me because I was very much part of the whole deal with them. As being part of the whole deal with them, they told me, I visited Florida where their main office was. So I went to Florida, visited them, and then they told me over there, why don't we do a study with this, a human study? I said, okay, fine, I'll go back to India and see what I can do. I came back to India and I was given the opportunity to give a lecture at the ISP, at the Indian Society of Periodontology. I was given an opportunity to lecture at the Indian Society of Perio. So when I was lecturing at the Indian Society of Perio, I found over there, after my lecture, approximately 15 to 20 PG students coming up to me and saying, sir, you told about so many new things happening in Perio. One of the new things happening in Perio is something called Novamin. And Novamin was not a product, believe me. It was not a product that time to be used by anybody. It was just in the scientific research labs of Novamin. Randy Scott, who was the president of the Novamin division, said that I want to take this forward. So I spoke to the students and there was one student called Neeru Mathur. And what Neeru Mathur told me is, sir, I would love to do this study for my PG. So I encouraged her. I set up the whole study protocol for her. I got her the material from USA and she did a study. And this study became a landmark study. This was a small, Noamin was a very, believe me, please understand what I'm saying. Noamin was a very small company at that point of time in the US, but it was a small company. We did this study for them or across patients. We did a study across 250 patients, and we found that more than 240 patients responded to the study and they were very happy with the results. Their sensitivity was almost eliminated. Neeru Mathur was happy, everyone was happy, I was happy. Randy Scott, who was the president of the company, was happy. And he said, we'll make it into a product. So they made it into a product which was also called Novamin. The product was also called Novamin. They did not want to confuse people, so they just called it Novamin. The name of the company was Novamin. The name of the product was Novamin. At that point of time, there was a multinational company. I will not name companies right now, but there was a huge multinational company, and this multinational company decided to take over Novamin. They wanted to buy out the technology of Novamin. In doing so, they contacted me. So I confirmed to them that this study was done by Neeru Mathur, etc. They said, we want authenticity. So they sent somebody from the US to India. I was with her. We traveled to Meerut. We saw all her studies. We saw all her papers and everything, and we were very happy with it. And the company, the multinational company, based on this full evidence, decided. Then, of course, I forgot to mention to you, this whole study was published in the International Journal of Dental Research. So it was a big publication for us in the International Journal of Dental Research. And based on this study, this multinational company decided to buy out Novamin. They paid some billions of dollars to buy out Novamin, which made Randy Scott a very rich person. And this company was taken over, this whole technology was taken over and then sold by the multinational company. And it was sold as what we call as Sensodyne Repair and Protect. This is what the material was called. New kind of care for your teeth contains brand new technology called Novamin. What Novamin does is nourishes the teeth with essential calcium and phosphorus ions for the natural self-repair, and contains the time-tested fluoride. It also contains fluoride, etc. They're all things that have been put into it, but basically what it has got is Novamin. It has got Novamin, and Novamin works like a dream. Now, so what do we have? We have the first method of depolarization. We use potassium nitrate based toothpaste, which works for 24 hours. Then you have to again brush with the same thing. You keep on doing it, you're fine. The day you stop brushing with it, the sensitivity comes back. The second way is to use one of the other materials to occlude the dentinal tubules. But occlusion of dentinal tubules works to a certain point. After that, it doesn't work at all. Because occlusal forces, brushing, etc., dislodges the occlusion of the dentinal tubules. Then came Novamin, and Novamin is a new material which was what? Which was so brilliant that it actually created a new hydroxyapatite-like layer, which was part of the tooth itself. So it was not subject to being removed by even a scaling procedure. It was always there, and it protected the exposed dentin and did not allow any stimulus to go to the dentin, and it worked lovely. Now, in addition to doing all this, we have to do certain small things. I will just talk about 3-4 additions, and then I will take questions from everybody. But I will do some 3-4 additions that we have to do. One is called occlusal adjustment. When we do a proper occlusal adjustment and lateral forces are removed, it stops the abfraction layer from creeping. Abfraction layer stops, it does not expand anymore. When abfraction doesn't take place anymore, it stabilizes everything and you don't get tooth hypersensitivity. Sorry, I'm going to talk about 2 more things. I wanted to talk to you about 2 more things which I have not mentioned over here. but I would like to talk about it. One was called the use of formalin. In my study, before when I was doing my post graduation, I was doing this, I was looking for different things that you could use to prevent hypersensitivity. And what I found was a lovely material which I could use called formalin. The formalin was so cheap. It was regular formalin which you took from the lab from the patho department. So I just borrowed some formalin from them. And how did I use it? Let me tell you how I use formalin. How I use formalin is like this, that on the tooth surface, wherever there was sensitivity, I took a small cotton pledget, dipped in formalin, and rubbed it on the tooth surface. And I rubbed it on the tooth surface, and then I had to make it evaporate. I had to make it evaporate. The tooth surface was open. I rubbed it on the tooth surface, and then what I did was I burnished it with a hot burnisher. I just heated a burnisher on the spirit lamp for a moment and taking care so that it will not touch the tooth surface at all. I just touched it wherever the formalin had been applied. Believe it or not, even today, if you want to do it this way, if you take a little bit of formalin and apply it on the tooth surface and then burnish it with a hot burnisher, the formalin evaporates and goes into the tubules and locks over there. Of course, I am not sure because I never did a full-fledged study on this, how long this would affect. But instantly, the effect was so good that the patient would be instantly happy with, oh my God, I don't have any sensitivity anymore. All my sensitivity is taken care of, all 100% controlled, all fine, all good. So they could take care of the sensitivity so beautifully in this manner. So this is one of the other ways in which I also treated sensitivity during my college days. So I've been involved with sensitivity for a long period of time. I was involved in the college. Then way later on in year 2000, I got exposed to Noamin as a technology, and I was privileged enough. Believe it or not, my paper, which was published along with Neeru Mathur, we published a paper, and my paper was part of the first ever published paper on Noamin in the entire world. After this, there were a few other people who published papers on Noamin, but mine, Neeru Mathur's and my paper was the first ever published paper on Noamin technology. So I was privileged enough to do that also. So that's about all that I want to talk about tooth hypersensitivity, because I know that I can just keep on talking about the inner details of it, but I don't want to do that. I've told you all the science behind it. I've told you how it works, and there we are. This is how sensitivity is treated. So thank you very much for this patient hearing. Now I will take all your questions, which were anything that comes to your mind. Please ask me, and I'll be happy to answer all the questions pertaining to sensitivity. Or even if there were some questions for Blue M gel, which were told to Nishant, I will answer those questions also. So thank you so much.
So there are some questions which I'll take up now.
Yes.
The first question I'll take up from the Blue M side only. So
Yes.
first question which is asked is by Dr. Jagdish Chandra from Mangalore, and he wants to know, are there any contraindication for the use of Blue M gel?
Well, Blue M is such a fantastic product which we spoke about. Minas Leventis spoke about it last time. I've been working with Blue M in India, and I found that Blue M has got absolutely no contraindication. Absolutely no contraindications. You can just use it anywhere and everywhere. Absolutely zero issues, zero problems, nothing at all. You can just use it all the time without any problem at all.
So we'll come to today's topic. So Dr. Reshu
Okay.
Sakya from Kathmandu wants to know that should we brush with Sensodyne Repair and Protect or apply it on an abraded surface directly?
The best way is ideally is to brush it. The best way is to brush it. Even if it is an abraded surface, brush it. Do not stop the patient from doing his regular brushing. Let the patient do his regular brushing and then let the patient take Sensodyne Repair and Protect and apply it on the abraded surface. And it will work wonders. Within 2 days, you will have resolution to your problem. Just do it and see it, and in 2 days, you will have a resolution to the problem.
So again, sticking to today's session, so
Okay.
Dr. Krishna Verma from Ghatsila wants to know which company in India is marketing Novomin.
Well, this company, which is one of the main company which marketed Novomin, is GSK, which was called as GSK, but it is now called as Helion. Sorry, Nishant, I had to take because the required to tell us the product. The dentists want to know what is the product.
Absolutely fine, sir. Absolutely.
So I had to tell them that it comes from a company called GSK, which is now called as Helion, and Helion makes the product. Helion has the rights for Novomin, but I have to also say that other than Helion, which was the first and only company for 10 years to sell Novomin, over the last 2.5 years or 3 years, there are other companies which have got the rights to sell Novomin based products also.
Right, sir. Then there are some questions based on today's topic itself. So this question comes from Dr. Milan Kumar from Bhubaneswar. He wants to know, in progressive periodontitis and ISDM patients, what is the role of antibiotics and which is the drug of choice today?
It is not today's topic because we're talking about antibiotics, but
it was
no
asked.
problem.
Yes, sir.
The antibiotics are fine. The antibiotic which is best used for a periodontal problem is coming from the company itself, the company which I've been talking about, Inkemi. They have got the best product. They have got a combination which has got amoxicillin and clavinic acid.
Thank
If
you,
you
sir.
were to talk to them for a moment about this.
I mean, sir, the combination is very well aware. We have our brand. Generally, our guys will reach out to doctor and probably, explain it to them. We market the product by the name of Inclab. So I'll come to the question again, sir. Then there's one question that has been asked by Dr. Siddhanta Gowda Patil from Bangalore, and he wants to know better cement to restore abrasion, GIC or composite.
Ideally, if you ask me as a person, I would use composite. I know there is a whole lobby which says that GIC has got a layer. It is not totally impacted by isolation. But what I believe in is this. If you got to use a restorative material to solve the abfraction lesion, you have to isolate. Without full isolation, it's not going to work at all. If you're going to fully isolate, then you might as well use composite only. Why go into GIC? Why not just regular composite? The way to apply composite is etch it, bond it, polymerize the bond, and then apply the flowable, and then apply the regular composite. And if you take care that no air is entrapped in the composite, you will never have an issue with it. You will never ever have an issue with it. Yes.
So then Dr. Srishti Srivastav from Siddharth, he wants to know any other best gel for gums except Hexigel?
Can you put a question across to her? I know what she's asking, what she's trying to ask, but I'm not too sure. You are using Hexigel for what? Hexigel basically is a hexidine-based mouthwash. Hexidine-based gel, sorry, not mouthwash, hexidine-based gel. And it is an excellent gel, but depends on what is the utility, what are you using it for? So if you could put the question to her and respond that what exactly is she using the Hexigel for, I'll come back to this question if she responds to it.
Absolutely fine, sir. We'll reach out to her. Then Dr. Krishna Verma from Gatsila wants to know how to manage sensitivity due to generalized attrition.
Generalized
Generalized attrition, that's what the
attrition.
question is.
Okay,
Yeah,
okay.
attrition. Yeah.
Generalized attrition. Well, the same way, if generalized attrition is there, that means it's all over the mouth. The best thing is to do a full mouth rehab. But of course, all patients cannot afford a full mouth rehab. So if you can't afford a full mouth rehab, what you can do is just put the patient on permanent Sensodyne Repair and Protect. Tell the patient to brush every day with Sensodyne Repair and Protect. That will keep the patient happy and fine. And he will say that I am so happy with this. I want to just continue using this. That's all you do.
Sir, based on your response, Dr. Siddhanagowda Patil has reached out and he has asked now that you mentioned in abfraction it is cementum and enamel is lost and not dentin. Is this correct, sir?
Yes, correct. 1 minute. I'll just explain. Let me explain this, Nisha.
Yes.
See, dentin is always covered by enamel on the crown area. The rest of it is covered by cementum. But if you have got recession, then part of the cementum is lost because this cementum cannot stay there. So the dentin is exposed. Or if some of the enamel has been abraded away, or because of erosion or any other thing, you have lost enamel, then again dentin is exposed. It is exposed dentin where enamel or cementum is not there anymore, which causes sensitivity.
Sir, I think these are the questions that I have, but there comes one more question comes from Dr. Resu Sakya from Kathmandu, and she wants to know, can Novomin solve post-restorative hypersensitivity?
Depends. If the post-restorative hypersensitivity is due to a trapped air bubble in the restoration, that will not get sorted. That will not get sorted. So that will not sort the problem. But if it is just a generalized sensitivity which is there because of some exposed dentin, then Novomin will sort the problem.
Dr. Patil had another question, sir, which I'll take up now. So he wants to know whether Novomin composition toothpaste is there or anything that you would like to add on this.
Yes, there is a Novomin toothpaste. Sensodyne Repair and Protect is basically Novomin toothpaste. It is calcium phosphosilicate.
Okay.
That is Novomin.
So Dr. Patil once again asked that what about Gluma desensitizer used after vital teeth preparation?
Yes. Gluma desensitizer is a good way. If you're doing a vital tooth preparation pre-restoration, you can definitely go ahead and use a Gluma desensitizer. Absolutely no problem. It is for a specific purpose, for a specific area, and you use the desensitizer and it works.
So Dr. Srivastava, Srishti Srivastava she reframed a question and she asked now that I want to ask sir, which is the best gel for bleeding gums?
For bleeding gums, the best gel.
Yeah.
I'll tell you what, the best thing for bleeding gums is scaling. Now, this does not answer your question properly.
Yeah.
Scaling is a procedure which you do in the mouth, where you remove all the plaque and calculus. Believe me, 99% of bleeding will vanish when you do a proper scaling in 48 hours to 72 hours. It will vanish. After that, if you still feel that the patient is complaining of some issues of bleeding, just put the patient on a 7-day Hexidin mouthwash. Put the patient on a 7-day Hexidin mouthwash. This should work wonders.
Absolutely perfect, sir. Thank you so much, sir. I think we have exceeded about our time, but then Doctor, again, I'll take the last question, which
Please
comes
take the
from
question.
Dr. Patil. He wants to know what about B complex and vitamin C tab post scaling?
Absolutely is no role to play. you can give it, but it's got no role to play post scaling. Since you are making a very pertinent question, you are talking specifically as post scaling. Post scaling, it has no role to play. It has a role to play for so many other things in dentistry. But if you're talking of post scaling, it has no role to play.
So Dr. Krishna Verma from Gatsila wants to know any homemade remedy for sensitivity.
None. None. The best homemade remedy is Noamin toothpaste. You have got Noamin as Sensodyne Repair and Protect, and you have got other molecules of Noamin also in various other combinations from various other companies. You can use any one of them.
So I've got one more from Dr. Patil.
Yes.
He wants to know any light on chromogenic bacteria stains last Q.
Last what?
Q. He spells that as Q. QUE.
Okay. Well, chromogenic bacteria is not going to be a problem, specifically if you are going to not use anything which is attracting the chromogenic bacteria from forming a stain over there. In 7 to 8 days, it's not going to cause a problem anywhere. I just spoke about using hexidine for after bleeding gums for 7 to 8 days, but that's all. It won't cause a problem.
Sir, I think we have not only exceeded our limit, but my quota of questions also almost over.
Okay.
So first of all, sir, thank you so much once
Most
again
welcome.
for having a wonderful and entertaining sessions for all. Again, sir, India and Nepal, we were joined by more than 1,800 doctors all across.
Lovely.
So that speaks in volume about the kind of impact the program has been able to make on the information level on various aspects of dentistry. So I thank you once again, sir, on behalf of Inkemi, and I thank all the doctors who took their valuable time out and
Thank you.
and joined this session. So thank you so
Thank
much,
you,
sir,
sir.
and good night to you all.
Good night.